Welcome back YouTubers to my channel of an everyday life of an Aspie. If you're new to my channel, I welcome you all. I'm Aspie. I'm all about creating mental health and awareness and sharing my life stories with Aspergers Syndrome, OCD and the like, along with tips and advice along the way, be it your general health versus your mental health, along with also some other, disorders that may come into play that is health related. So it has been put to my attention, as said, that some of the stuff that I have been trying to hope to bring out to you will be maybe on a back burner, but hopefully it won't be too much of a hassle. So in all of further ado, guys, I'm going to try and do as many of the different disorders that is in the different organisation of our body systems versus everything else, as well as hopefully also more on the autism and series that I was hoping to bring out, along with some fun and games along the way of what I've been up to, one of which is going to be on the back burner, which I humbly apologise that's taking a bit longer than expected, is the one that I mentioned if you've been following me on my social media sites, of the tea cozy. So this one's going to be a real, hopefully short, brief one based on the genetic disorders that I'm going to put under the playlistings, one of which is very rare, and hopefully you'll enjoy this and you'll learn something along the way. Smash the like button if you're liking some of these, and hopefully with some of these we are learning something along the way. And if you've got some of these kind of conditions that I bring out, or disorders, just feel free to comment below how you go about your everyday living about this, so we can learn from each other and maybe hope for the best that we can understand each other, because like I said, I just don't want us to come into a conflict or anything like this. I just hope that we can just learn from one another and actually be friendly on this channel. So this one, as I said, is a real one, which is called 22q11.2 syndrome, Deletion syndrome, basically, in which, before I begin, I'm no medical doctor, I'm just a normal Joe blog, so if you see anything out of the ordinary, do seek professional advice with your doctor or clinical experts, because if you see any of these warning signs and symptoms, seek professional help for yourself or your loved one. So let's begin this. As I said, this is 22q11.2 Deletion syndrome. There are some other names for this condition or disorder, shall we say, and they are as follows: chromosome Q 22q11.2 Deletion syndrome, which I've already mentioned, and also the Velo Cardio Facial Syndrome, or VCFS they call it, and so on and so forth. I'm going to, as I said, try to make it short and brief. So what you might be asking is, what is this form of disorder or syndrome? This is a disorder that has been involved with many different areas of the body that can vary greatly from different person to person in severity scale with this condition. The signs and symptoms may include that you may look at is the cleft palate, heart deficits, recurrent infections, unique facial characteristics, feeding problems, kidney anomalies, hypoparathyroidism, thrombocytopenia, scoliosis, hearing loss, developmental delay, and learning disabilities. Somewhere on the screen will be showing you a body part of, or shall we say the whole entire body, that will show the most common to the least common of these, bits and pieces of these disorders, of the, signs and symptoms that I'm sharing with you all. People with this condition will also, or are more likely to develop certain autoimmune disorders and personality disorders. With this syndrome of 22q11.2 Deletion syndrome is caused by a deletion of a small part of the chromosome, which is your chromosome 22, near the middle of the chromosome, that is at a location known as q11.2. In most cases, the syndrome occurs for the first time in the affected person. About 10% of some cases are inherited from parents. It is inherited in an autosomal dominant manner. Although there is no specific treatment or cure for this disorder, there can always be ways in managing the symptoms, however. A team of doctors is often needing to feeding out the treatment options based on each person's symptoms, though, however. Many children with this disorder have developmental delays, including delayed growth and speech development and learning disabilities, as I mentioned, and later in life they are at an increased risk of developing mental disorders such as ADHD and developmental conditions such as Autism Spectrum disorders that may affect the communication and social interaction with your peers. Because of the signs and symptoms of 22q11.2 Deletion syndrome are usually often varied from person to person, different groupings of features were once described as separate conditions. Doctors named these conditions DiGeorge Syndrome, Velo Cardio Facial Syndrome, also known as or called Syndrome, and Connor-Trunstall anomaly face syndrome. In addition, some children with this condition were diagnosed with the autosomal dominant form of Autism syndrome and Velo Cardio Facial Syndrome. Once the genetic basis for these disorders were basically identified by the doctors then will determine that they were all part of a single syndrome with many possible signs and symptoms. To avoid any confusion, though, however, this condition is usually often called 22q11.2 deletion syndrome, a description which is based on the underlying cause of the genetics. So therefore, if you want to know more about what I'm sharing with you, or based on some of these bits that you want to learn from me, basically give me the heads up by, thumbing it up, or so just commenting it below of some of these other syndromes I've listed, so that we can learn from each other. The symptoms, once they try to roll up what it is, are as follows. The signs and symptoms of the may vary greatly from person to person as to their mind, as I keep saying. I can't stress it enough. Even among the affected people in the same family unit. The most common symptoms may include heart deficits, which are 74% of individuals that may have this, abnormalities with the development of the palate, 69% of the individuals, characteristic facial features such as elongated face, almond-shaped eyes, wide nose and small ears, almost like they look like a little elf, you may call them, but we need to be careful about how we say it and go about this. Learning difficulties will affect at least 70 to 90% of the individuals. Immune system problems, 77% of the individuals. And some of the additional symptoms may include low levels of calcium, which is 50% of individuals, significant feeding problems, kidney abnormalities, which is 31% of the individuals, hearing loss, issues with the development of the larynx, trachea and esophagus, laryngogastrophysical abnormalities, growth hormone deficiency, autoimmune disorders such as your thrombocytopenia, juvenile rheumatoid arthritis, overactive thyroids, seizures, skeletal abnormalities such as your extra fingers, toes and ribs, wedge-shaped spinal bones, craniosynostosis, psychiatric illnesses, eye abnormalities, ptysis, columbia, cataract, and strabismus, central nervous system abnormalities, developmental delay, intellectual disabilities, and learning differences are also common in individuals with this syndrome. Individuals may also have an autism spectrum disorder, psychiatric illness, attention deficit disorder, anxiety, repetitive behaviours, and also difficulty with social interactions are also common with people with this syndrome. The causes. This is caused by a missing piece or deletion of part of the chromosome 22 in each of the cells in the DNA. The deletion occurs near the middle of the chromosome on the Q arm at a location known as Q11.2. Most people with 22q11.2 deletion syndrome are missing a piece of chromosome 22 that contains about 30 to 40 genes, many of which have not been well characterized. However, some people may have smaller deletions. Researchers are working on to learn more about all of the genes that has contributed to the features of this deletion syndrome. The deletion of a particular gene, TBX1, is thought to be responsible for many of the syndrome's characteristic signs and symptoms, however. Loss of this gene may also contribute to behavioral problems. The loss of another gene, COMT, may also cause increased risk of behavioral problems and mental illness. The other genes that are deleted are likely to be contributed to the various features of 22q11.2 deletion syndrome. And the inheritance. Most cases of 22q11.2 of the syndrome aren't inherited from a parent and are caused by a random error during the formation of the egg or sperm cells when, they do fuse together, or even during the fetal developmental stage. In about 10% of the cases of this, the deletion is inherited from a parent with the deletion gene. When the deletion is inherited in an autosomal dominant pattern. This means that having the deletion and only one copy of chromosome 22 in each cell is more than enough to cause features of the condition that I'm sharing. There's nothing that either parent can do before or during a pregnancy to cause a child to have this condition. When a person with a deletion that causes an autosomal dominant condition has children, each child has a 50% chance or 1 in 2 chance to inherit this disorder. In the Diagnostics Testing, this is diagnosed in individuals with a submicroscopic deletion of chromosome 22 detected by a fluorescence in situ hybridization or FISH, multiplex ligation dependent probe amplification MLPA, or chromosomal microarray CMA. At present, fewer than 5% of individuals with clinical findings of the 22q11 deletion syndrome have normal routine cytogenetic studies and normal results on FISH testing. However, this figure may change as individuals with atypical or nested deletions within the GCR DiGeorge chromosome region, but not including the area encompassing the N25 or total FISH probes, are identified using array-based or MLPA technologies. For the treatment for this manifestations is with the multidisciplinary team approach, which may include any combination of the following: allergy, audiology, cardiology, cardiac surgery, child development, psychology, dental, endocrine, ENT, feeding, gastroenterology, general pediatrics, general surgery, immunology, clinical genetics, neurology, neurosurgery, ophthalmology, orthopedics, otolaryngology, plastic surgery, psychiatric, pulmonary, rheumatology, speech and neurology, tailored to the affected individual's specific needs. However, calcium supplementation and referral to an endocrinologist for hypocalcemia and thyroid monitoring, specific strategies, modification of spoon placement when eating, treatment of gastroesophageal reflux and gastrointestinal dysmorphology for feeding difficulties, educational intervention and speech therapy, introduction of sign language therapy beginning at diagnosis for the risk of delays. Growth hormone deficiency, however, is treated as in the general population. Immune deficiency requires aggressive treatment of infections, rarely prophylactic antibiotics, IVG therapy, or thymic transplantation may be required. Early diagnosis and intervention for psychiatric illness will improve long-term prognosis, however. For the prevention of secondary complications such as immunization of infants who have lymphocytes abnormalities with live vaccines isn't recorded, re-evaluate immune status in childhood before giving these live vaccines. Antibody studies to access results of immunizations are warranted. Irradiated blood products are recommended until normalization of the immune system can be confirmed. Serum ionized calcium concentration should be measured pre and post-operatively to avoid hypocalcemic seizures. Consider assessment of carotid arteries prior to surgical procedures involving the pharynx. Consider possible effects on speech prior to angiostomy. Consider assessment of cervical spine abnormalities prior to hyperextension of the neck during surgical procedures. Athletic pursuits. Consider pre- and post-operative sleep studies when performing pharyngeal procedures. Consider assessment of palate volume and function prior to surgical procedures. Surveillance. Follow-up is needed on a system-by-system basis, obviously, is important, but including routine reassessment of serum ionized calcium and thyroid studies, re-evaluation of immunologic status prior to live virus vaccines, annual completed blood count and differential, ophthalmic evaluation prior to school age, evaluation of nasal speech quality, audiology evaluation prior to school enrollment, surveillance for sclerosis, routine dental care, regular speech, language, and development instruments to provide appropriate mediation. Ages and circumstances to avoid: carbonated drinks if possible, and alcohol consumption may exacerbate to hypocalcemia. Caffeine intake may contribute to or worsen anxiety if they do suffer from anxiety. Genetic counselling. 22q11.2 deletion syndrome is a contiguous deletion inherited in an autosomal dominant manner. About 93% of probands have de novo deletion of this condition, and 7% have inherited this condition from a parent somewhere. Offspring of affected individuals have a 50% chance of inheriting this disorder. Prenatal testing for pregnancies at increased risk based on family history is possible if the diagnosis has been confirmed in an affected family member, and for pregnancies not known to be at increased risk, which congenital heart disease and or other associated abnormalities such as your cleft palate, polydactyly, diaphragmatic hernia, renal abnormality, and polyphylinosis have been detected by the ultrasound examinations. Treatments. The resources provided information about treatment options for this condition. If you have any further questions though about which treatment is right for you, if you have it, talk to your healthcare professional. Management guidelines. Gene Reviews provides current expert author peer-reviewed full-text articles describing the application of genetic testing to this diagnosis, management and genetic counselling of patients with inherited conditions. To establish the extent of the disease and the needs of an individual diagnosed with this disorder, the following evaluations are recommended if not performed as part of the evaluation that lead to the diagnosis. Management. A baseline cardiac evaluation by a cardiologist that includes a chest x-ray, ECG and echocardiogram. A chest MRI may be required if a vascular ring is suspected. Measurement of serum ionized calcium concentration and intact parathyroid hormone level to excess for hypothyroidism, followed by a formal endocrinology evaluation if abnormal. TSH level, complete blood cell count with differential, a low absolute lymphocyte count necessitates evaluation of T and B cells subsets and referral to an immunologist. Renal ultrasound examination to evaluate any structural renal defects. Consideration of ophthalmology and elevation. Audiology evaluation, chest x-rays to evaluate for thoracic, vertebral and normally cervical spine films, 6 views, flexion, extension, AP, lateral, open mouth, skull base in all individuals over the age of 4 years, the age that the cervical spines become better ossified, clinical evaluation of the palate to screen for palatal anomalies which may affect the feeding and speech development. Assessment for possible feeding problem includes significant gastroesophageal reflux, difficulty with sucking, swallowing, advancing feeds and position of textured foods, vomiting and constipation. Speech and language assessment by the age of 1 year can be given almost to all children with this syndrome. Have delay in emergence of language and would benefit from the early intervention stages. In addition, such as evaluation aids, diagnosis of palatal abnormality, as an evaluation of children with short stature, height below the second percentile by an endocrinologist for possible growth hormone deficiency, evaluation by psychologists or psychiatrists of any person with evidence of anxiety, mood disorders, behavioural differences or frank psychosis, evaluation by a hematologist of any person with a history of a bruising, bleeding disorder. Prognosis. There is a wide range of symptoms and severity among these people with this syndrome. The long-term outlook for each person will depend on the specific signs and symptoms each individual will have. Factors that may impact the severity of the disease and likelihood for a shortened lifespan include whether or not a congenital heart deficit is present and how severe the deficit is, as well as severity of immune system problems. For instance, individuals with complete absence of the thymus gland and absent T cells may pass prematurely. Well, this quickly ends basically the 22q11.2 deletion syndrome information. Hopefully you like this. Smash me the like button, comment below, feel free to follow me on my social media sites, feel free if you want to be part of my YouTube family to subscribe, no pressure if you don't want to, feel free to, if you have decided to turn on the notification bell so you can keep up to date with new information and status quo of what I've been up to. So enough for the video guys, thanks for watching, do what you love what you're doing, until next time, Aspie signing out and I'll see you all again soon, ciao for now.